Hello, it's Dan Hilleman, and we're going to talk about management of poisoning and overdose in our ongoing series of presentations for advanced critical care therapeutics. Obviously, poisoning and overdose is something that we have to deal with fairly commonly, and the list of potential poisons or drugs that we could deal with in an overdose situation is vast. And so, in terms of time restraint, we obviously are limited to talking about those that occur with a certain amount of frequency, or the other, end of the spectrum may not occur very often, but have such high rates of morbidity that it requires, it impels us to discuss those. So anyway, management of overdose and poisoning. If you go to the second slide, obviously drug poisoning or toxic exposures, some of these are accidental. I mean, children, older adults get confused. Others are deliberate self-poisoning attempts at suicide. 2.4 million cases of admission to emergency departments every year in the U.S. 220,000 of these result in hospital admissions that can't be resolved in the emergency room. About 2.5% to 5% of all ICU admissions are due to drug overdose or poisoning. Lengths of stay are relatively short, 2.5 to 3.5 days. But ICU mortality is predicted at somewhere between 3 and 6%. If you go to the next slide, the drugs that are most commonly involved in adult poisoning are analgesics, sedatives, hypnotics or antipsychotics, antidepressants, cardiac drugs, anticonvulsants, antihistamines, and then, interesting enough, stimulants and street drugs are kind of at the bottom of that list. You would think it might be more common, but I think part of that is that opiate overdose gets lumped into that category of analgesic, if you will. And go to the next slide. I think, general considerations in terms of poisoning and overdose. One is recognition. You have to have a diagnosis where there's a history of exposure, the clinical course is consistent with poisoning, and you have to rule out other causes of signs and symptoms that occur. The classic features of overdose with specific drugs are often referred to as what are called a toxidrome. Instead of a syndrome, they call it a toxidrome. And when you have polysubstance ingestion, which can occur frequently, then there's overlapping toxidromes, and it may be difficult to pin down the specific agent that's causing the toxicity. The time course, generally onset is brief, minutes to up to maybe hours, and progress over a maximum of several hours and typically resolve within a couple of days. Go to the next slide. Identification, obviously, unknown pills or products, the Poison Control Center. In your local community, we have one here in Omaha. Poisindex, which is available online, may help you identify unknown pills or capsules. There's a lot of generics out there today. If you have something that's been ingested that's a plant or a mushroom, or there's been an insect or reptile bite, then you may have to rely on local experts at zoos, universities, maybe professional societies to figure out what's going on. Mental status changes and other physiologic parameters such as blood pressure, heart rate, temperature, pupil reaction can be a useful guide to help ID unknown agents. It gives you some sense of, it probably would be more likely to be one type of substance than another. Go to the next slide. Some general considerations also would include prediction of potential toxicity. What was the magnitude of the ingestion? Is it likely to be a lethal quantity? How much time has occurred since exposure? I think we have to assume worst case scenario in these settings. simply because we'd rather be, safe than sorry, so to speak. You'd rather provide more care than insufficient care. Beware of delayed toxicity. There are some drugs, substances that are considered toxic time bombs: acetaminophen, lithium, methanol, and then drugs that are incorporated in either sustained release or extended release preparations. There are an awful lot of non-toxic exposures. If you look at that original slide, the number of overdoses that come into the ED that are managed without being hospitalized, then, some of those are clearly, they don't produce significant organ toxicity. So those that are not toxic, there are a list of things that we should probably look at and ensure. Asymptomatic by history and physical exam. We've identified the amount and type of all toxins involved. We know the time from exposure. The exposure dose is less than the smallest dose known to produce significant toxicity. And the elapsed time since exposure is greater than the longest known time interval between exposure and onset or peak of toxicity. So if you can kind of address each of those issues, that allows you to reach a conclusion that it may be a non-significant exposure. Now we go to the next slide. There are a number of I guess, again, as I mentioned, physiologic reactions that would allow us to, if you will, decide what type of drug may have been involved with an overdose. And it certainly doesn't include every substance, but it includes the ones that most often are associated with significant overdose. So for instance, drugs that affect body temperature. Drugs that cause hypothermia would be your cyclic antidepressants, opioids, alcohols, barbiturates, hypoglycemic agents, and lithium. On the other hand, drugs that promote or are associated with hyperthermia, drugs that tend to increase metabolic rate are amphetamines, anticholinergic, antihistamines, cocaine. Interesting enough, cyclic antidepressants have been associated with both hypo and hyperthermia, so that's probably not very helpful. Salicylates, and then patients who have malignant hyperthermia or neuroleptic malignant syndrome, neither of which are drug overdose related, are also associated with hyperthermia. Next slide. Drugs affecting heart rate. Well, the drugs that can cause tachycardia, obviously, are typically drugs that stimulate sympathetic nervous system activity: amphetamines, anticholinergics, antihistamines, cocaine, cyclic antidepressants, drug withdrawal, theophylline, and thyroid hormone overdose. Whereas those drugs that can cause bradycardia are antiarrhythmics, beta blockers, calcium antagonists, cyclic antidepressants, which again, these drugs show up in both categories, so not very helpful. Digoxin, and then lithium. So again, if you have a patient that presents with bradycardia as a predominant finding, that would suggest amphetamines probably not the major cause of the overdose. Drugs that affect blood pressure. Those that can increase blood pressure, again, oftentimes are those that stimulate sympathetic nervous system activity: amphetamines, epinephrine, ephedrine, pseudoephedrine, cocaine, tricyclic antidepressants, antihistamines, drug withdrawal. This would include, methamphetamine as well, which is a fairly common problem in terms of illicit drug use. Hypotension, beta blockers, calcium antagonists, narcotics, tricyclic antidepressants, typically late, and then iron, nitrates, theophylline, colchicine, possibly can cause hypotension as well. Go to the next slide, drugs that affect pupil size, and I always kind of, it's easy to, what's meiosis, what's mydriasis? Well, mydriasis, the key to remember is that mydriasis is dilation of the pupil, and it has the letter D in it. So one way I remember mydriasis is D for dilation, whereas meiosis is constriction, contraction of the pupil. So meiosis, barbiturates, carbamates, clonidine, ethanol, isopropyl alcohol, and opioids. Whereas dilation of the pupil, amphetamines, anticholinergics, antihistamines, cocaine, cyclic antidepressants, drug withdrawal, and monoamine oxidase inhibitor reactions. So if we go to the next slide, and I'm not going to read through this, this is again for your information, for your edification. Common toxic syndromes or toxidromes are listed here, and they're listed by the syndrome. There are a number of anticholinergic drugs, there are a number of sympathomimetics, narcotics, sedative hypnotics, serotonergic drugs, and cholinergic agents. And each of these produce relatively similar signs, symptoms, and they have different causes, different types of drugs that fit into those categories. But these are the toxidromes that I think one would expect that these are some of the more common culprits that we have to deal with in the critical care setting when patients present with poisoning or overdose. So if we go to the next slide, which is titled Treatment Overview, initial stabilization, supportive therapy, the ABCs, airway, breathing, circulation, gastrointestinal decontamination, which would be lavage, enhancement of elimination, which would be administration of cathartics, removal of toxins, dialysis, etc., supportive care, fluids, ventilators, and then antidotes, direct antidotes for certain poisons. And there is a nationwide poison control center consultation, and I've given you the phone number on this slide, which should be relatively easy to remember. If you have a local poison control center, certainly you can use that as well. But if you're in an area and you don't know if the poison control center is open or available, there's 1-800 numbers available 24/7. So the next slide, some general considerations. If these are patients that are having significant toxicity, coma, hypotension, respiratory depression, arrhythmia, seizures, temperature extremes, agitation, etc., they need to be admitted to an intensive care unit. Patients that are less ill, stable, or asymptomatic can be admitted to an intermediate floor or maybe a telemetry floor, or just kept in the emergency room until a decision's been made that this was a non-toxic exposure. Obviously, understanding about anecdotes are important. And so, I think this is one area where, again, we don't often just rely on our memory as to how we manage specific poisoning or overdose situations, but having adequate resources that we can access that tell us about the anecdotes, how to use them, what the indications, contraindications, dosing, and complications are important. So having an overdose or poisoning handbook, either there in hard copy or online, is essential. There are some non-selective antidotes that include correction of underlying metabolic derangements and increasing non-metabolic chemical elimination that can be used kind of broad spectrum, if you will, for a variety of overdose or poisoning situations. If we go to the next slide, then some of the supportive care obviously is respiratory. Prophylactic intubation would be recommended for patients that don't respond to or use voice, so they don't respond to your command. They don't verbalize a response. They cannot sit upright. They can't drink fluids. A gag reflex should probably not be used to assess the need for intubation. But obviously, once you've decided that you need to intubate, then adjunctive therapy is required: paralytics, sedatives, anticonvulsants, antipsychotics. A cardiovascular support, obviously blood pressure, pulse, rhythm. Invasive monitoring may be needed for severe cases, an art line, maybe a triple lumen catheter. Pretty uncommon, but for patients that have a history of cardiac disease. Hypotension, generally you're going to use volume before you go to some of the vasopressors. For hypertension, benzodiazepines may be all that's needed, anti-anxiety medication. And don't forget that a lot of arrhythmias are due to metabolic derangements, typically electrolyte imbalance, magnesium, potassium, and correcting those without the need to give antiarrhythmics makes more sense. So look at the underlying cause. Next slide. Neuro and neuromuscular support. Patients that are having hyperreactivity are at risk for rhabdomyolysis and an increase in body temperature. Patients that have taken sympathetic or hallucinogenic drugs oftentimes can be sedated with benzodiazepines. Seizures generally managed with benzodiazepines rather than barbiturates, but barbiturates certainly would be considered a second line. Isoniazid-induced seizures we treat with pyridoxine. Paralyzed with neuromuscular blockades only when sedatives, benzodiazepines, anticonvulsants don't work. The problem there is that they continue to have seizure activity, which can lead to permanent neurologic damage. So some of these patients may need to have ongoing electroencephalographic monitoring to make sure that seizure activity has ceased. Initial management of patients that come in with mental status changes, coma for instance, they need to be intubated, especially, you want to get that O2 sat up to at least 92%. Dextrose, at least an amp of D50, 100 milligrams of thiamine IV, and naloxone 0.2 to 0.4 milligrams IV, and you can repeat the naloxone dose. So you have a patient who comes in, you can't get a history on, they're unconscious, you make sure they're not hypoxic. If it's an insulin reaction, the dextrose should restore their blood sugar and bring them out of the diabetic coma. Thiamine, for a number of conditions that can cause encephalopathy, and then obviously naloxone for opiate overdose. So if we go to the next slide then, talking about some general considerations, interventions that would increase elimination or decrease absorption of toxins. And these are some important things to keep in mind. One, cathartics are generally not recommended. There's relatively little clinical benefit of giving laxatives, enemas, etc. Ipecac is not recommended. No clinical benefit. And a lot of we've taught for years, induce emesis for for overdose, but the experts are telling us that Ipecac may do more harm than good. Gastric lavage is not routinely recommended, although what we used to call having your stomach pumped. If it's a recent ingestion and there's a significant amount of drug left in the stomach, perhaps it may play a role. A whole bowel irrigation, again, not routinely recommended, but perhaps for long-acting drugs that have been incorporated into enteric-coated or sustained-release delivery. Urine alkalinization with bicarb for salicylate intoxication is one of the few specific recommendations for that strategy. Single-dose or multiple-dose activated charcoal. There are some places where this is beneficial, particularly if it's been, a 1 hour since ingestion. There are certain drugs that can be absorbed by the activated charcoal. But multi-dose activated charcoal is not recommended routinely, but may be useful for certain drugs like carbamazepine, dapsone, phenobarb, quinine, and theophylline. There are other drugs that dialysis may be required, and you have to know, again, and this is where reference material comes in handy, rather than trying to remember every drug. Is the drug substantially cleared by hemodialysis? So lithium, certain alcohol, salicylate, valproate, and theophylline are drugs that could be potentially removed by dialysis in life-threatening situations. So what we want to do is spend the rest of the time talking about specific, what I consider highly toxic overdose drugs, and then what's the management strategy for each of these. Acetaminophen continues to be probably the most common overdose, other than perhaps alcohol, which oftentimes people just simply sleep it off. But acetaminophen overdose, particularly those that result in hospitalization, this is one of the more common ones we have to deal with. 70,000 ER visits a year, 300 deaths annually. Acetaminophen, recently the FDA has said they're going to cut back on amounts of acetaminophen that can be incorporated in combination products. But it's in literally hundreds of products combined with opiates, antihistamines, decongestants, all kinds of cough and cold preps. And so overdose can be a chronic problem and not just an acute ingestion. The toxicity that's secondary to a single ingestion, or it could be due to that excessive repeated or too frequent dose. And so, clearly many of the acetaminophen cases that we deal with are not, in patients that are trying to commit harm to themselves. So if we go to the next slide, pathophysiology of acetaminophen overdose has been known for a number of years, but 90% of single doses are metabolized by glucuronidation or sulfation to non-toxic metabolites. But about 5% is converted to this N-acetylbenzquinone amine, which is abbreviated NAPQI. It's converted by cytochrome P450, and it's extremely hepatotoxic. NAPQI is rapidly detoxified by glutathione to form cysteine and mercaptopuric acid conjugates. So if you can, what happens is if you take enough acetaminophen, you exhaust the amount of hepatic glutathione that's available, and you end up with hepatotoxicity because this NAPQI is not, this intermediate metabolite is not being rapidly converted to cysteine and mercaptopuric acid. So there are 4 phases of acetaminophen poisoning. We'll talk about these in a couple of minutes as well in more detail. But preclinical toxicity, before, the toxicity can be delayed because it takes a while for the glutathione stores to be depleted. Preclinical, generally your ALT is normal. Then hepatic injury occurs where increases in ALT are present. Hepatic failure, where the injury now has progressed to the point that you develop encephalopathy. And then finally, hopefully, recovery. Each stage has a different prognosis and is treated somewhat differently. Treating patients during the preclinical stage, some of these folks may go on and develop some injury, but almost all of them recover. Treating patients during the injury phase, where they have increases in ALT, the outcome is variable. And treating patients who already have encephalopathy, mortality is 20 to 40%. So clearly, the earlier the intervention, the better. And we have ways of knowing, using an algorithm, what patients need to receive the antidote. So these are the phases, again, of acetaminophen toxicity on the next slide. Phase 1 typically occurs earlier than 24 hours. It is associated with anorexia, malaise, pallor, nausea, vomiting, diaphoresis. Phase 2, abnormal LFTs, right upper quadrant pain, meaning that the liver is starting, obviously, to be damaged. Occurs typically at 24 to 48 hours. Phase 3, 48 to 96 hours, there's encephalopathy, coagulopathy, and hypoglycemia. All of these are a result of the fact the liver is failing. The liver function test will peak, and rarely pancreatitis, acute renal failure, MI may occur because of the overdose. And then phase 4 is the recovery phase. Typically after 96 hours, the enzymes start to normalize, and this is where you either recover or death occurs. If we look at management, and this is, I don't know the slide, the next slide says pathophysiology, but it really is related to pathophysiology. The management is based on pathophysiology, and that is what we want to do is to replace, replenish, increase hepatic glutathione stores. How do we do that? Well, we do that by administering N-acetylcysteine, which reduces hepatic injury by increasing hepatic glutathione. So in patients who've already developed hepatic failure, N-acetylcysteine improves hemodynamics, oxygenation. It improves clearance of indocyanine green, which is a marker of hepatic function, and decreases cerebral edema. The exact effects by which these benefits occur is unknown, but may result from free radical scavenging or by changes in hepatic blood flow that have nothing to do with the availability of glutathione, because once the liver cells have died, there's a limited amount of regeneration. So again, the point is we do treat people at all three phases of presentation with N-acetyltransferase, with N-acetylcysteine. But some of the benefits are unexpected in patients with advanced liver disease in the setting of acetaminophen poisoning. This drug was first used in 1974. You can give it orally, you can give it IV. The largest study was done in 2,540 patients, typically treated in the first 10 hours. The ALTs were over 1,000 and 6%, compared to 26% that had increased ALTs that were treated after 10 hours. And in those patients with hepatic failure, administration of N-acetylcysteine reduced mortality by 20 to 30%. So even in the folks where you've got encephalopathy, this is an antidote that still has significant benefit. So the next slide, the initial laboratory evaluation of an acetaminophen overdose is to get a level of acetaminophen, generally 4 hours or more after ingestion, because that's the time it takes for absorption to occur. Now, one of the things that we're going to see with the nomogram is that it's not been generally tested in patients that have been taking long-acting delayed release forms of acetaminophen. So at baseline, you're going to get your liver function test, ALT, AST, prothrombin time, which is an indication of clotting factors, and serum creatinine. Salicylate levels, because oftentimes these folks have ingested combination products. Tox screen, just to make sure you're not dealing with a multi-product overdose, and then arterial blood gases. Next slide. Clinical management. There is some evidence that a single dose of activated charcoal may reduce the need for N-acetylcysteine if given within 2 hours of ingestion. And it doesn't appear that the activated charcoal interacts with N-acetylcysteine. The initial use of N-acetylcysteine is best when patients present within 24 hours after ingestion, between 4 and 24, because we normally don't get a good reading on acetaminophen levels if it's less than 4 hours. If it's less than 4 hours, then the activated charcoal may be beneficial. The Rumack Matthew, and it was originally just called Barry Rumack at the University of Colorado, was the one that developed this nomogram. What it does is stratify patients by acetaminophen level into risk of developing significant liver damage. And it is best applied to patients who have had a single acute ingestion of immediate release acetaminophen. So what we do is we'll look at the nomogram in a minute, but patients that have acetaminophen levels above the line are at risk. Those below the line are not. And so the decision to treat or not to treat is based on the nomogram, given the caveat that this is a single one-time ingestion of an overdose. The nomogram is not useful if the time to ingestion is unknown. Any patient with a supertherapeutic acetaminophen level greater than 20 mics per ml and an unknown, and a known overdose, we treat those patients. Repeated doses, you treat if the dose is greater than 4 grams per day and the acetaminophen level is greater than 20 mics per ml. Extended release preparations, you can repeat the acetaminophen level 4 to 6 hours after the first level, assuming the first level is below the line. If it's above the line, then you're going to have to treat anyway. Regardless of the time of administration or the time of ingestion, N-acetylcysteine is beneficial in patients who have elevated liver enzymes. This is the Rumack-Matthew nomogram, and what you have on the y-axis is plasma serum acetaminophen concentration from 1 up to 500, and obviously it is not to scale, and purposely not to scale. And along the x-axis are hours post-ingestion. So it's really, again, only useful from 4 hours up to 24 hours, and for, again, immediate release, acute ingestions. So they have, if you will, 2 lines, one that is probable risk, the other possible. Most people, possible means treat. If it's under the line, means no risk, then you would just monitor, but keep in mind the caveats that if this is an extended release prep, then you may need to wait and repeat your level of acetaminophen. How to use N-acetylcysteine in an acetaminophen overdose on the next slide. Orally, the protocol is 140 milligrams per kilogram as a load, and then 70 milligrams per kilogram every 4 hours for 17 doses. If you're giving it orally and the patient vomits within 1 hour after administration of a dose, then the dose should be repeated. If they can't hold it down orally, then you're going to have to go with the IV route. One caution is using this in asthmatics. It may provoke some bronchospasm. The IV dose is 150 milligrams per kilogram load over 15 minutes, and then 12.5 milligrams per kilogram per hour for 4 hours, and then 6.25 milligram per kilogram per hour for 16 hours, the total being 300 milligrams per kilogram. The dose does not need to be adjusted for renal or hepatic disease or if dialysis is used. Some toxicologists believe that 72 hours is too long for oral and 20 hours is too short for IV. So that's just something to consider. If you're a physician and you deal with this, You'll have your opinion one way or the other, but that's what the protocol says. The ALT and acetaminophen level is repeated at hour 16, and you have to continue the infusion if either is elevated. There really isn't controlled evidence comparing IV or oral. Oral certainly is convenient in people that aren't, sick, but N-acetylcysteine, for those of you that have used this stuff, the capsules are probably easier to take if you're trying to use the injection as oral. It has a bad sulfhydryl, rotten egg type odor, flavor, and so the capsule formulation, I think, may be easier to tolerate orally. Again, if the patients vomit or have altered sensorium, give it IV. If it's hepatic failure, give it IV. And again, 20 hours may be too short, for the IV, according to some of the experts. The next slide, the adverse effects are relatively modest with N-acetylcysteine. Unpleasant smell and taste, may cause vomiting, flushing. So some of these patients you may get by if you give them an antiemetic drug. But the estimate is only about 5% of patients need N-acetylcysteine IV. The most common side effect with the IV form is rash, pruritus, angioedema, bronchospasm, tachycardia, or hypotension. Doesn't happen very often, but the suggestion is that about 15% will have one of these manifestations within 2 hours of the initiation of the IV. Increasing the infusion from 15 minutes to 60 minutes didn't reduce the rate of the anaphylactic reaction. If patients develop itching, diphenhydramine certainly can be used. If they develop more severe evidence of allergic reaction, angioedema, hypotension, bronchospasm, then diphenhydramine, corticosteroids, and bronchodilators may need to be administered. And some suggest if this is happening acutely, stop the IV and restart an hour later at a lower dose, obviously with pre-treatment with those adjuvant drugs. The next slide, predictors of poor outcome, obviously late presentation, grade 3 or 4 hepatic encephalopathy at presentation, a prolonged pro time, acidosis, pH less than 7.3, renal failure, cerebral edema, sepsis, or Apache 2 score greater than 15. And some of these patients may need a liver transplant. And the King's College criteria, which suggests that they may need a liver transplant, is persistent pH below 7.3, very high INR or very high pro times, and a creatinine greater than 3.4 with presence of grade 3 or 4 hepatic encephalopathy. So in those patients, they've crumped their liver to the extent that they need liver transplant to survive. Okay, cocaine, we went through the disco 80s, and cocaine, I think, began a run of popularity that ultimately led to development of more potent forms that were not snorted but smoked, crack, which I think continues to be a problem in major urban areas. But freebasing is also still a form of administration that I think overdose of any delivery can produce serious toxicity. The hydrochloride salt is water soluble and easily absorbed. It can be given IV, so it can be injected as well. Freebase and crack are not water soluble, but those are smoked, heated typically in a pipe, and inhaled. And then, of course, overdose can occur in patients that are body packers. This can occur with heroin or with cocaine or whatever drug that trying to be smuggled in. The body packer will swallow a drug that's been concealed in latex packets, and these occasionally can burst in the GI tract, and then you end up with massive overdose due to absorption of large quantities of drug. Next slide, pathogenesis. Cocaine is an indirect sympathomimetic agent. It promotes release of neurotransmitters, dopamine, epinephrine, norepinephrine, blocks the presynaptic reuptake, so you have this massive sympathetic response. You have a local anesthetic type effect, sodium channel blocking effect, so you get an activity that looks like a class 1 antiarrhythmic agent. Cocaine promotes platelet aggregation, so you end up with an increase in blood pressure, heart rate, contractility, coronary vasospasm, and arrhythmias. And oftentimes, that's the cause of death is VT or VF, which is the terminal event. Cocaine is extensively metabolized in the liver by hepatic esterase, plasma cholinesterase, and non-enzymatic hydrolysis produces some metabolism, but very little cocaine ends up cleared unchanged in the urine. What I'm trying to say, obviously, is that cocaine is predominantly metabolized in the liver. After IV or inhalation, by smoking crack or freebasing, the onset of the effect is very short, 3 to 5 minutes. Cardiac response at 3 to 12 minutes, and a duration that's relatively short. After inhaling it nasally, nasal insufflation or snorting cocaine, the onset's delayed 15-20 minutes, cardiac effects at 20 to 60 minutes, and you get a much longer duration of action. Clinical presentation on the next slide for cocaine: changes in heart rate, blood pressure, respiratory rate. Temperature is somewhat proportional to the degree of poisoning. Obviously, temperature is elevated. Mild poisoning, essentially the vitals can be normal, blood pressure, heart rate, but you'll have anxiety, agitation, euphoria, headache, tremor, twitching. They may have some GI, nausea, vomiting, diaphoresis, mydriasis, which again is dilation of the pupil, and pallor. They look pale. Moderate toxicity, they can then start to have some CNS confusion, hallucinations, hyperactivity, clonus, increased muscle tone, abdominal cramps, seizures, and potentially rhabdomyolysis, which produces brown or tea-colored urine, and acute renal failure. In severe overdose, malignant hyperthermia, cardiac arrhythmia, status epilepticus or coma, apnea, cyanosis, Cheyne-Stokes respiration, and cardiovascular collapse, either due to bradycardia, hypotension, or VTVF, can be the terminal event. So you do have, obviously, varieties of severity of cocaine toxicity, and part of it, I think, is, oftentimes a novice user that ingests too much will have more severe reactions than a seasoned user, abuser that has developed a certain amount of tolerance. Management of cocaine poisoning, again, is dependent on severity, but the first thing is advanced life support and monitoring. If they have central nervous system changes, oxygen, dextrose, thiamine. Benzodiazepines can be used for anxiety, agitation, seizures. Barbiturates for refractory seizures, thiopental. These patients may need to be paralyzed and intubated. Moderate hypertension and tachycardia, often benzodiazepines alone will be enough. More severe hypertension, a parenteral titratable drug such as nitroglycerin or nitroprusside, calcium channel blocker, phentolamine, can be used. Beta blockers probably not recommended for cocaine ingestion because Beta blockers, even the cardioselective drugs, even an esmolol, for instance, can block the beta-2 receptor, allow for unopposed alpha receptor agonist effect, coronary vasoconstriction, and increase cocaine toxicity. The issue is that blood pressure, if you normalize blood pressure, the patient still may have some myocardial ischemia due to coronary vasoconstriction. So coronary vasospasm, nitrates, calcium blockers, alpha blockers, maybe morphine, would be preferred to treat myocardial ischemia. I think the patient that once you have blood pressure under control and they continue to have ischemia, then you may consider beta blockers after you've taken adequate steps to make sure that the coronaries are adequately vasodilated. So if you've got a calcium channel blocker on board, IV nitro, patients continue to demonstrate some ischemia, then I think a beta blocker may be permitted. And labetalol, certainly because of its alpha blocking effect, might be a consideration. Labetalol is predominantly a beta blocker that has some alpha blocking activity. Arrhythmias should be managed following the guidelines, ACLS, but one thing that can be done for cocaine toxicity is to add some bicarb to your algorithm. The bicarb tends to block cocaine from its receptor and promotes cocaine elimination. And so that's one setting where bicarb may play a role. Body packers, endoscopic or perhaps open surgical removal, this is potentially useful in these patients. And certainly, if intestinal obstruction occurs, these are folks who are going to need surgery to remove, the pellets of latex packed cocaine or whatever substance happens to be in those packets. Several in the next slide, several alcohols and glycols can be accidentally or intentionally ingested. Ethanol, which is used in beverages or in grain alcohol, methanol, which is called wood alcohol, isopropanol or isopropyl or rubbing alcohol, and then ethylene glycol, which is antifreeze. All of these are central nervous system depressants. Ketoacidosis and hypoglycemia can occur. Hormonal, nutritional, metabolic, and intravascular volume changes secondary to alcohol consumption are what are responsible for producing the acidosis and hypoglycemia. Toxic metabolites are generally formed by alcohol dehydrogenase, and there is some renal toxicity associated with ethylene glycol, ocular toxicity with methanol, and anion gap metabolic acidosis with both of those alcohols. Excuse me. So we'll talk about each of these specifically, but ethanol toxicity obviously is related to the level of tolerance. There are some chronic alcohol abusers, ingesters that can, have very high levels of alcohol and not have significant toxicity. But generally, for the novice drinker, the levels of alcohol, 100 milligrams per deciliter produces ataxia, 200 milligrams per deciliter drowsiness and confusion, and at 400 milligrams per deciliter respiratory depression. So the conversion to what you hear about legal limits, which most states have dropped to 0.08, is 80 milligrams per deciliter. It used to be 0.1, and that's 100 milligrams per deciliter. But so these folks that Some can tolerate levels 200-300 and be look relatively normal in terms of functionality if they have a high tolerance for ethanol. Electrolytes, blood ethanol, glucose, serum osmolality should be checked on admission. IV fluids, glucose, thiamine administered. If they have severe respiratory or CNS depression, then they may need to be intubated. Gastric lavage has been suggested if it's been within an hour since the last ingestion. Charcoal is generally not helpful because ethanol is absorbed very rapidly. And generally you hold and observe these patients until they're sober and their ethanol levels have dropped below 100 milligrams per deciliter. Isopropyl alcohol or rubbing alcohol, it's 70% isopropyl alcohol. It's metabolized to acetone. It's more toxic than ethanol at any level, and so 50 milligrams per deciliter is associated with intoxication, 100 to 200 milligrams stupor and coma. So it's a much more toxic substance than the ethanol that we use in social beverages. Nausea, vomiting, abdominal pain, respiratory, depression, hypotension. Oftentimes you'll see ketosis, but the pH will be normal. You can look at directly measuring isopropyl alcohol levels, though that most labs can do that. Do not induce emesis. Lavage and charcoal if the ingestions occurred within the last hour. Mostly the care is supportive. If hypotension persists despite supportive therapy, dialysis will remove isopropyl alcohol from the system. Methanol is an antifreeze. They use it in cars, carburetor fluid, windshield washer fluid. It's in sterno canned heat, which contains both methanol and ethanol. Toxic ingestion can occur with as little as 15 milliliters up to 400 milliliters. Apparently it doesn't taste bad. It has a sweet taste, and so leaking antifreeze on parking lots, dogs can drink the stuff and get sick and die. Obviously alcoholics have drank methanol as a way of trying to get drunk. But what's produced by methanol is formaldehyde and eventually acetaldehyde dehydrogenase converts it to formic acid. So those are the toxic intermediates in methanol. Initial symptoms: lethargy, confusion followed by hangover. Toxic symptoms can often be delayed. Ethanol ingestion along with this prolongs the onset of symptoms because it competes for the same enzyme that converts methanol to its toxic intermediate. Neurologic, ophthalmologic, and GI symptoms predominate: hemorrhagic gastritis, pancreatitis, which the warning sign should be abdominal pain, nausea, vomiting, diarrhea, headache, visual disturbance, so blurred vision, loss of acuity, whiteness in the visual field, nausea, vomiting, abdominal pain, tachypnea, respiratory failure, and then coma and convulsions are usually occur in severe cases and would be responsible for fatal outcome. The diagnosis for methanol poisoning is to get both ethanol and methanol levels, look at your ABG, severe anion gap metabolic acidosis, pH, and acid base are probably better predictors than methanol levels themselves. So how do we treat methanol poisoning? So do not induce emesis. Gastric lavage if it's been within 1 hour of ingestion. Charcoal does not absorb methanol. Folinic acid or leucovorin can be administered 1 milligram per kilogram, a maximum of 50 milligrams, followed by folic acid 1 milligram per kilogram every 4 hours for 6 doses. This increases the conversion of formate metabolism. Bicarb can be administered for severe acidosis and may prevent or reduce permanent vision damage. Fomepizole is a specific antidote that's been on the market for several years. I think all emergency departments should have this product available. But it's an alcohol dehydrogenase antagonist, so it decreases formation of the toxic metabolite. So it is, which in this case is formaldehyde. It is FDA approved, and it went through approval by orphan designation. You can get it from Orphan Medical, and the phone number's on the slide. Indications for fomepizole are a peak methanol level greater than 20, or an anion gap metabolic acidosis after a suspicious ingestion. 15 milligrams per kilogram IV as a bolus, followed by 10 milligrams per kilogram per hour for 12 hours. Every 12 hours for 4 doses. So it's not given as an infusion; it's given as an intermittent IV injection. 15 milligrams per kilogram IV can be given until the methanol level drops below 20. And if the patient's on dialysis, they're in renal failure, then the dosing differs, and I would just suggest trying, rather than memorize the dose for dialysis, check the package insert. Again, this is something that should be available in emergency departments, particularly in large urban areas that may see these methanol overdoses. Ethanol delays conversion of methanol to its toxic metabolite. It competes for alcohol dehydrogenase and can be used if fomepizole is for some reason not available. So IV ethanol is available commercially, 7.5 to 10 mLs per kilogram of 10% ethanol can be given IV, or 0.8 to 1 milliliter per kilogram of 95% alcohol can be given orally in orange juice, pretty stiff drink. But obviously, if you don't have fomepizole, this could be potentially life-saving. Maintenance doses depend on prior alcohol exposure. 10% ethanol in a non-drinker. The dose is 0.8 milliliters per kilo per hour. In a moderate drinker, 1.4. Chronic drinker, 2. And during dialysis, which removes alcohols, obviously, then you can increase the dose anywhere from 2.7 up to 3.9 milliliters per kilo per hour. Obviously, the goal is to produce an ethanol level of 100 to 130 milligrams per deciliter, and you want to check that after loading and 2 to 3 times per day during maintenance. Keep blood sugar in the normal range, and you're going to continue your ethanol until the methanol level is below 10 milligrams per deciliter, or the formate level is below 1.2 milligrams per deciliter. Acidosis resolves, CNS symptoms abate, and the anion gap is normalized. Hemodialysis can be used if your methanol level is above 50, or if you have severe resistant acidosis, renal failure, or the patient starting to develop visual symptoms. Ethylene glycol is antifreeze, and the initial symptoms resemble ethanol toxicity, nausea, vomiting, CNS depression, seizures, coma. Patients may develop heart failure and pulmonary edema at 12 to 24 hours after ingestion. They may develop oxalate crystal deposition in the kidney, causing oliguric renal failure. Back pain or flank pain associated with those stones may be the presenting symptoms. Ethylene glycol levels, the anion gap, metabolic acidosis assessed by ABGs, oxalate and empiric crystalluria that causes hematuria and proteinuria are typical findings in these patients. You obviously don't induce an emesis as with any of the alcohols. Charcoal and lavage are typically not effective because absorption is relatively rapid. Correct the acidosis with bicarb. Fomepizole is used in the same manner as it is with methanol. You could give ethanol, just as you did for methanol poisoning, as an alternative to fomepizole. A couple of things you do differently here is one is you give pyridoxine 100 milligrams IV and thiamine 100 milligrams IV every day. Dialysis for glycol levels greater than 50, unless on fomepizole, with a normal pH and asymptomatic, because you know that the conversion to the toxic intermediate is being blocked by fomepizole. If the pH is less than 7.25 or 7.3, then you may consider dialysis. The patients that don't respond, they continue to deteriorate despite treatment with fomepizole. Electrolyte abnormalities that don't seem to respond to standard therapy. Dialysis is continued until the glycol level is less than 10. The glycolic acid level is undetectable, and acidosis, anion gap, and clinical status are stable. Opioid overdose, again, you know, in large cities and I guess even in some smaller ones where heroin, or now today with the widespread availability of oral opioids that seem to be making their way around, oxycodone, Vicodin, Percocet, things like that. Opioid overdose, remains a major issue in most emergency rooms. Obviously, CNS and respiratory depression, meiosis are the hallmarks of opioid overdose. The pupils may be dilated with acidosis, hypoxia, or after meperidine or diphenoxylate plus atropine ingestion. So the meiosis, which is constriction, is not always what it may seem to be. Overdose with a special type of opioid, alpha-methylfentanyl, which often is referred to as China White. Often when you do an opiate screen, it may come up negative. Heroin is often cut with scopolamine, cocaine, or caffeine, which may complicate the clinical picture. Obviously, caffeine or cocaine are going to produce different effects on heart rate and blood pressure than heroin would. Management, obviously ABCs, and try to reduce further drug absorption. Emesis is contraindicated. Lavage charcoal if ingestions occurred within 1 hour. Whole body lavage, or excuse me, whole bowel lavage, or irrigation for body packers. Endoscopic removal and surgery if there's bowel obstruction. Naloxone on the next slide is obviously the drug of choice for opiate overdose. It can be given by almost any route, IV, IM, sub-Q, sublingual, intranasal, or via endotracheal tube. It's not effective given orally is the only caveat. The goal of giving naloxone simply is to achieve spontaneous respiration. Use of naloxone to the point that to achieve complete arousal may precipitate withdrawal, particularly in tolerant patients. So you need to be careful with the extent to which you reverse the effect of the opiate. Accidental overdose and opioid abusers or tolerant individuals generally respond to low doses of naloxone. 0.05 up to 0.1 milligram given intravenously. Repeated doses are often needed. The duration of a naloxone dose is about 45 minutes. Larger doses may be needed for propoxyphene, diphenoxylate, buprenorphine, or pentazocine, which have longer durations of action. Intentional overdose in non-tolerant individuals may require large doses up to 10 milligrams. Initial dose in this setting is 0.4 to 2 milligrams. Isolated opioid overdose is unlikely if no response occurs to a total dose of 10 milligrams of naloxone. If there is recurrent toxicity, naloxone can be given by an infusion. And the longer acting drugs like methadone, levoalpha-acetylmethadol, or sustained release preparations, OxyContin or MS-Contin, that you may need to use an infusion. The initial hourly infusion rate is about 2/3 of the bolus needed to reverse toxicity. And you titrate your rate of naloxone infusion basically to prevent respiratory depression, but at the same time you don't want to precipitate withdrawal. And so, there's a fine line in terms of titrating your naloxone infusion in these individuals. Cholinergic poisoning can be a problem, particularly in rural areas where certain insecticides are used. And so, these include the nerve agents that are used for chemical warfare. There are some direct pharmaceutical cholinergic receptor stimulants, bothanicol, pilocarpine, urocholine, that could be, taken in excessive quantity. But the acetylcholinesterase inhibitors, organophosphates, and carbamate insecticides, malathion, parathion, a lot of those have been banned, but carbamate drugs, edrophonium, physostigmine, central acetylcholinesterase inhibitors like donepezil, chemical warfare agents, again, this is the sarin gas that you probably have heard about. And so, what happens with cholinergic poisoning is that you increase the effect of acetylcholine at cholinergic receptors, and so the way that we manage these folks is by using anticholinergic drugs that either accelerate clearance or block the effects of acetylcholine. Next slide. Cholinergic poisoning. The onset of toxicity can be minutes to hours after either dermal, pulmonary, or oral exposure. Acetylcholinesterase inhibition, generally we divide it into muscarinic, nicotinic, and CNS side effects. So the mnemonics to describe symptoms here are dumbbells and sludge. So dumbbells are diarrhea, urination, meiosis, bronchospasm, emesis, lacrimation, and salivation. Sludge is slightly different. It's salivation, lacrimation, urination, defecation, and gastric emesis. So you can take that for what it's worth, but it does adequately describe what these folks are going through. Death generally occurs secondary to respiratory, depression, and diaphragmatic weakness. The severity of organophosphate poisoning correlates with the degree of depression of red blood cell cholinesterase activity, but most institutions don't have the ability to measure red blood cell cholinesterase levels. It has been done, in experimental settings, and they divided severity of poisoning based on this red blood cell cholinesterase level. 20 to 50% of baseline is mild, 10 to 20% of baseline is moderate, less than 10% of baseline is severe. But again, most labs can't do this, and it would only be helpful if it were available on a stat basis. So cholinergic poisoning, the management strategy, one is aggressive dermal and GI decontamination, lavage and charcoal if exposure within 1 hour. Emesis is contraindicated. ABCs, obviously airway, breathing, circulation. Preservative-free atropine, 1 milligram IV. If they don't have any side effects, then 2 milligrams every 15 minutes until atropinization occurs, which typically it depends on the amount of exposure. Clearing bronchial secretions and adequate oxygenation are good therapeutic endpoints to tell you that the patient's received adequate amounts of atropine in this setting. This is not like we're treating bradycardia, where 3 milligrams is the maximum dose. Tachycardia and pupillary dilatation are not reliable indicators of adequate atropine administration. The average dose is 40 milligrams, but some patients may need as much as 500 to 1,500 milligrams per day. And obviously it's easier to administer those kind of doses as an infusion. Treatment may last several days. One thing to note, atropine does not reverse muscle weakness. So, one of the things that's done for severe cholinergic agent poisoning is to administer pralidoxine, which reactivates cholinesterase and counteracts the weakness, muscle fasciculation, and respiratory depression. So 1 to 2 grams is typically given IV, which breaks down to 25 to 50 milligrams per kilogram. It's put in 100 mLs of normal saline and administered over 30 minutes. You can repeat that every 6 to 12 hours, a maximum of 12 grams per 24 hours. Alternatively, you can give it as 500 milligrams an hour, 10 to 20 milligrams per kilogram per hour, as needed for several days. Pralidoxine is usually not required for carbamate poisoning, which is a reversible inhibitor. Seizures in this setting are treated with benzodiazepines and maybe phenytoin. And in severe cases where parathione overdose occurs, hemoperfusion may be considered. One thing about pralidoxine, one of the side effects is hypertension, and so you may need to manage that. We talked a little bit about that when we talked about hypertensive emergency. Antidepressant overdose, fortunately, is a thing of the past for most institutions, simply because of the advent of the availability of the selective serotonin reuptake inhibitors. The traditional tricyclic antidepressants are not used anymore in any great quantity, not at the doses that were available at one time, but they're still potentially lethal if taken in overdose. So patients that are using tricyclics for neuropathic pain, they may present with an overdose, and there are some newer agents that we're not certain what to do with. I mean, they probably have less toxicity, venlafaxine, bupropion, nefazodone, but again, you have to look at the clinical picture. Clinical manifestations of traditional tricyclic overdose is anticholinergic, so mydriasis, ileus, urinary retention, hyperpyrexia. Cardiac, the thing that was lethal in these patients was an increase in the QT interval, causing torsade, heart block, and then hypotension, and that's a lethal combination. If you alpha blockade and drop your blood pressure, and you're also in sustained polymorphic VT, that's a recipe for death. CNS, agitation, confusion, stupor, seizures, and eventually coma. Plasma levels, if they're available, do correlate with severity of symptoms. Generally, levels above 1 mic per ml are associated with an increase in cardiovascular toxicity, but again, there are not very few labs available that are doing imipramine or whatever amitriptyline levels. So these folks, typically, if it's a significant ingestion, they need cardiac monitoring. You need to normalize electrolytes. No ipecac, lavage, or charcoal. They really don't have evidence of benefit in this setting. One of the things about antidepressant overdose is that we learned that if you alkalinize the patient with bicarb to achieve a pH of 7.45 to 7.55, you increase protein binding of the antidepressant and reduce toxicity. It will reduce hypotension, arrhythmias, and conduction disturbances. So bicarb drips are part of the management strategy for patients that are having significant cardiovascular toxicity with a tricyclic overdose. Intubation obviously would be a strategy for patients that, that if you want to hyperventilate them to achieve a higher pH, that would be a strategy as well. Torsade, when it occurs in the setting of antidepressants, is managed more or less the same as it would be in any setting. Obviously, you can't, the drug's already absorbed, it's in the system, but magnesium, overdrive pacing, isoproterenol, the guidelines that we talked about in management of arrhythmias would apply here. Obviously, avoid drugs that are going to also prolong the QT interval. Alkalization does not diminish or reverse the CNS toxicity. So physostigmine, which crosses the blood-brain barrier, 2 milligrams IV over 1 minute does reverse CNS depression, but you're going to need to give repeated doses. The only problem with physostigmine is that it may worsen arrhythmias and seizures. So supportive care generally is what's recommended for patients in coma. Treat the seizures with benzodiazepines and phenytoin. And if those don't work, then you go to plan B, which is barbiturate, paralysis, general anesthesia, and you may have to monitor seizure activity with EEG. Beta blocker toxicity on the next slide. Again, this could be accidental, it could be intentional. Clearly, pretty obvious what occurs: bradyarrhythmias, conduction disturbance, hypotension, CNS depression, seizures, bronchospasm. Bradycardia, heart block may respond to atropine but may need temporary pacer support. Hypotension, sodium, normal saline, glucagon, the other catecholamines, epinephrine, norepinephrine, may need to be used to support blood pressure and cardiac output. Beta-2 agonist will probably be preferred for bronchospasm. Seizures, treat with benzodiazepines and phenytoin. And if you have a water-soluble beta blocker, something like nadolol or sotalol, atenolol, they can be cleared with dialysis. Calcium channel blocker toxicity, the next slide, lavage, if it's been within 1 hour of ingestion. Charcoal may also be beneficial, but no emesis. If it's a sustained release preparation, and there's a lot of calcium channel blockers in sustained release delivery systems, then gastroscopy or whole ball irrigation may find some undigested tablet fragments in the gut. Seizures, benzodiazepines, phenytoin, but dialysis is a little benefit. All of these drugs are extensively metabolized and not cleared by dialysis. Drugs used in calcium channel blocker toxicity include calcium chloride, glucagon, insulin glucose, catecholamines, maybe amrinone to support cardiac output. Again, most of this is based on severity of toxicity, and what extent your blood pressure has dropped. I mean, the three major effects of calcium blockers are hypotension, heart block with perhaps bradycardia, and then heart failure secondary to reductions in contractility. And all of these are drugs that will reverse some of those effects. The next slide actually gives you kind of a stepped scenario for what drugs you can use in patients that are, that have received overdoses of calcium channel blockers. They're hypotensive. You considered charcoal, optimized fluid and electrolytes. They've got a reduction in cardiac output. They've got a reduction in vascular resistance. Vascular resistance is going to be managed dopamine, calcium, norepinephrine, glucagon, and then maybe insulin glucose. The reduction in cardiac output, inotropes, maybe a milrinone, maybe a catecholamine like epinephrine could be considered. It just depends on severity of the overdose. The bradycardia with calcium channel blockers, atropine, and calcium chloride, beta agonist, glucagon, again, insulin, glucose, and perhaps a PDE3 inhibitor, pacing, ultimately, if all of the above fail. And I'm not certain that, if you've got a severe overdose, pacing wouldn't be something that wouldn't be considered higher up in this algorithm. On the next slide, digitalis toxicity. We still see a fair amount of patients taking digoxin, and there are obviously instances where unintentional dig overdose occurs. There may be the occasional patient that's attempted suicide. EKG abnormalities, all kinds of different kinds of arrhythmias can occur. The classical supraventricular tachycardia with AV block, but you can see accelerated junctional rhythms, you can see third-degree AV block, you can see VT, you can see VF. Almost anything can occur in terms of cardiac electrophysiology with dig toxicity. Neurologic, usually altered mental status, weakness, visual. Patients may have blurred vision, color alterations, see halos around the outline of objects. Gastrointestinal, nausea, vomiting, abdominal pain, diarrhea, all can manifest. Some factors to consider, in patients that are prone to dig toxicity, advanced age, underlying cardiac disease, respiratory disease, renal insufficiency, it leads to accumulation. Patients who are hypothyroid are more sensitive to dig. Patients that have electrolyte disturbances, hypokalemia, hyperkalemia, hypercalcemia, hypomagnesemia, and then drug-drug interactions. There's a lot of drug interactions that will increase blood levels of dig. Amiodarone certainly is one of the most common that will double to triple the effect of digoxin. Management, oftentimes, the overdose is not severe. One thing I would tell you that generally the dig level is not necessarily highly predictive of severity of toxicity. Multi-dose activated charcoal can be considered because of enterohepatic recirculation. Atropine for bradycardia or heart block. You may need a pacemaker. Digibind is generally, it's the direct antidote. It binds dig in the bloodstream and pulls it out of tissue. If you have life-threatening ventricular arrhythmias, myocardial depression, potassium levels above 6, you may also want to give glucose, insulin, and bicarb if they're acidotic. You want to be very careful trying to cardiovert these patients. And so, if you're looking at doing something before the digibind kicks in, phenytoin historically had been suggested, magnesium, as potential antiarrhythmic agents to counteract the dig effect in terms of causing arrhythmias. The dose of digibind varies with the amount of dig that can be neutralized. One vial of digibind, 38 milligram, neutralizes 0.5 milligrams of dig. Chronic therapy, if no dig levels available, 6 vials for adults, 1 vial for small children less than 60 kilos. Basically estimation of dose. If you have a blood level available, we know the volume of distribution of dig is about 5 liters per kilo. So that will be able to tell us how much drug we think the patient ingested based on blood level and volume of distribution. Acute ingestion of a known amount, the number of vials, the dose is total to the dig body load in milligrams divided by 0.5. The formula is based on a steady state dig level. And so if you look at the serum DIG concentration times weight in kilograms divided by 100, that also can be used to estimate the number of vials. Generally, you give the Digibind over 30 minutes unless cardiac arrest is imminent, and then you can give it as a bolus. One of the things that happens as you start to bind the digoxin, potassium levels are going to drop, AFib may reoccur, heart failure may get worse because the effect of the DIG is being reversed. One thing that's important to recognize is that DIG levels are really of no value after administration of Digibind, because the DIG assays will measure DIG that's bound to the Digibind antibody. Now on the next slide I have some tables that I think are probably a better tool to use to estimate the amount of Digibind that you need to administer in different situations of DIG toxicity, rather than trying to calculate numbers of vials and amount of drug to give. You can use these nomograms. And table 1 on this slide is the approximate dose of Digibind for reversal of a single large DIG overdose. So this is the patient that's attempted to commit suicide with digoxin. Tells you the number of DIG capsules or tablets that you think have been ingested based on 0.25 milligrams per tablet, and then the number of Digibind vials. If you have a serum DIG level and you know the patient's weight in table 2, you then can calculate the number of vials of Digibind that will be required for adults. And table 3 is the estimate based on infants and small children. Again, they may get into grandpa's DIG and swallow some tablets inadvertently. And so the dosing there is somewhat different in terms of the amount of Digibind that's administered. Turning the page, next slide, caustic ingestion can occur, alkaline solution or acid ingestion. Alkaline ingestions include lye, some automatic dishwasher detergent, oven cleaners, hair relaxers, toilet bowl cleaners. You know, children sometimes get into these things and inadvertently swallow this stuff. You know, the problem is that these alkaline solutions can cause deep tissue injury of the aerodigestive tract. It's not just the gut, but they inhale the fumes, which irritate the lung. Esophageal injury occurs in 30 to 40%. Vomiting, drooling, stridor, esophageal stricture can occur. Gastric injury and perforation are more common with liquid lye. Treatment is immediate rinse of the oral cavity. Do not attempt emesis. No charcoal, catharsis, or lavage. Do not attempt to titrate the alkaline ingestion with an acid. Basically, it's protect the airway and give oxygen. Endoscopy may be indicated for esophageal injury. Administering steroids in this setting is controversial and generally not recommended. So the management here is basically supportive, but if necessary, a surgical intervention may be required. You know, if you have a lot of tissue damage, they may need to be intubated and ventilated if they've had a lot of lung damage as a result of the inhalation. Acid ingestion, and acids are found in toilet bowl cleaners, drain cleaners, metal cleaners, battery acid, swimming pool cleaners. Again, Lord knows why these things would be attractive, but individuals do accidentally drink these things. Small children typically who don't know better. And again, it's aerodigestive tract injury, although typically the amount of tissue damage with acid, interestingly enough, is less than with an alkaline solution. So rinse the mouth thoroughly. Do not attempt to neutralize the acid with alkali. Emesis, charcoal, lavage are contraindicated, and an endoscopy may be required. Sucralfate may ease some of the symptoms of the erosions that occur, but probably doesn't reduce complications. And administering prophylactic steroids or antibiotics is generally not recommended. Lithium, again, lithium, I think because it is given in a specific subgroup of patients that typically have mental illness, is often a source of overdose, partly because it has a relatively narrow therapeutic risk-benefit profile, and so some of the overdose may be accidental, but some may be intentional. The therapeutic range is 0.8 to 1.25 milliequivalents per liter. Excretion is renal, and it competes with sodium for excretion. The absorption with immediate release lithium is complete within 1 to 6 hours. The peak at 2 to 4. Sustained release may take a couple of days for absorption to be complete. Dehydration increases lithium reabsorption, and renal failure decreases lithium clearance. Obviously, both of those increase the toxicity. Doses greater than 40 milligrams per kilogram are toxic. Lithium levels correlate with toxicity. Greater than 1.5 usually is mild. 1.5 to 3 is moderate, and greater than 3 is severe. Mild toxicity usually is associated with tremor, ataxia, nystagmus, and lethargy. Severe toxicity, seizures, coma, arrhythmias, hypotension, nephrogenic diabetes insipidus. Treatment, you can do lavage if ingestion occurred in the last hour. Charcoal does not bind lithium, so it does not make sense. Interestingly, Kayexalate may decrease absorption. If lithium levels continue to rise because a sustained release product was administered, whole bowel irrigation with polyethylene glycol solution may be reasonable. Hydrate to maintain appropriate euvolemia. Definitive treatment is dialysis. Typically, dialysis is recommended when you have blood levels above 3.5 to 4. After acute ingestion or chronic ingestion where levels are 2.5 or higher. So acute, you tolerate a little higher level, chronic, a little lower level. Worsening mental status, seizures, arrhythmias, renal failure, dialysis is indicated. And the goal of dialysis is to bring that lithium level down to less than 1 milliequivalent per liter. Salicylate ingestion, since the invention of childproof caps, the baby aspirin that's orange that has a candy-like flavor. We used to see a lot of salicylate aspirin toxicity. Interestingly enough, there have been cases of methyl salicylate toxicity from using topical products. But, we still see individuals that either overdose on this because of chronic or acute ingestion. Acute ingestion, generally, the doses that are associated with mild toxicity are less than 150 milligrams per kilogram. 150 to 300 is moderate, and 300 to 500 milligrams per kilogram is severe. Chronic ingestion, more than 100 milligrams per kilogram over several days, can produce toxicity. Often, toxicity is delayed and associated with significant mortality, which can be as high as 25%. Symptoms are nausea and vomiting, tinnitus, usually at levels greater than 30 milligrams per deciliter. Malaise, fever. The presence of fever is a poor prognosis in adults. Severe toxicity, lethargy, convulsions, coma with cerebral edema, non-cardiac pulmonary edema, and occurs in up to 30% of adults, and it's more common with chronic ingestion. Generally, respiratory alkalosis occurs early, followed by metabolic acidosis. A salicylate level at 6 hours after ingestion needs to be assessed. You may look at a level earlier than that if you think it's an acute or severe intoxication. Levels greater than 70 at any time indicate moderate to severe intoxication. Levels greater than 100 milligrams per deciliter is usually fatal, very serious toxicity. Chronic ingestion, the levels are not as helpful. Or if it's an enteric-coated preparation. Again, the levels may not be as important as other manifestations of toxicity. So bicarb levels and pH are useful predictors, especially in patients who are using salicylates chronically. So the management strategy, obviously ABC, the supportive care, airway, ventilation, activated charcoal, urine and serum alkalinization with bicarb, supportive treatment, aggressive rehydration, manage hypoglycemia, and dialysis. You can, on the next slide, use lavage if the ingestion has occurred within 1 hour, multiple dose activated charcoal. You can produce an alkaline diuresis. If the blood level is greater than 40 milligrams per deciliter, you can put 100 milliequivalents of bicarb in a liter of D5 and run that at 10 to 15 milliliters per kilo per hour until you have an adequate urine flow. You can then decrease the rate to 2 to 3 milliliters per kilogram per hour. Monitor your urine output, urine pH. You want your urine pH alkaline, 7 to 8. And monitor your potassium. You usually are going to need to add at least some potassium to every liter, 20 milliequivalents or so, because of the alkalinization. You do need to be cautious with your fluid resuscitation, patients with comorbidities, heart failure, renal failure. Do not use acetazolamide. It promotes urinary alkalinization, but it also promotes systemic acidemia, which worsens salicylate toxicity. Dialysis is indicated if you have levels between 100 and 130 after an acute ingestion, or greater than 40 with chronic administration. Other indications for dialysis would be refractory acidosis, severe CNS symptomatology, progressive clinical deterioration despite your best efforts, pulmonary edema or renal failure. Pulmonary edema is best managed with mechanical ventilation and cerebral edema with hyperventilation and osmotic diuresis. This is the nomogram that's been worked out for salicylate. Obviously on the y-axis the salicylate level, and you can see that at most points in time up to about up to at least 48 hours, salicylate levels less than 40 are going to be okay, but mild, moderate, severe, obviously moderate to severe is going to require more aggressive intervention. But this is a helpful nomogram in terms of structuring your treatment strategy. Patients with moderate to severe toxicity probably need to be managed in an intensive care unit. Patients with mild may be able to be managed in a less aggressive treatment area in the hospital. So again, just to, on the next slide, to the fact that salicylate toxicity can be fatal, particularly with chronic ingestion, but also acute ingestion. Just to be redundant, indications for hemodialysis and salicylate overdose. Acute overdose greater than 120, greater than 100 post-ingestion, meaning if it's been absorbed, 140, after 4 hours. Refractory acidosis would be an indication. Neurotoxicity, renal failure, and then cardiovascular instability, arrhythmias, hypotension would be an indication for hemodialysis in these patients. Fortunately, on the next slide, barbiturates at one time were considered, if you will, the drugs of choice for suicide. They were used as sleeping pills. and they've essentially been replaced with other safer drugs for insomnia. There still are some barbiturates on the market: phenobarbital for seizures, butabitol for headache, but for the most part, barbiturates have been removed from the market, and that's a good thing. Toxicity does vary with the dose, the type of barbiturate, and time since ingestion. Short-acting drugs, toxicity occurs at lower doses, but the longer-acting barbiturates actually produce more fatalities because their effects persist. Mild intoxication resembles initially ethanol poisoning. They appear drunk, but with more severe forms of intoxication, greater CNS depression, diminished response, they may only respond to painful stimuli, reduction in deep tendon reflexes, slowed respiration, and severe intoxication, coma, loss of all reflexes except pupillary light reflex. Hypotension and hypothermia can occur, no electrical activity on the EEG. So management, folks typically have to, with severe intoxication, they need to be intubated and ventilated. Obviously, no emesis. Lavage may have some benefit if ingestion occurred in the last hour, and multi-dose activated charcoal may be considered if it's a long-acting drug like phenobarbital. Forced alkaline diuresis enhances phenobarb toxicity, but not for short-acting barbiturates. But we really don't have many short-acting barbiturates on the market anymore. Hemoperfusion will remove phenobarb and short-acting barbiturates from the circulation. On the next slide, benzodiazepines cause CNS and respiratory depression, but rarely result in fatalities unless ingested or mixed with other respiratory depressants, alcohol, for instance, other toxic substances. Drowsiness, dysarthria, ataxia, slurred speech, confusion are common. Treatment: no emesis, lavage if ingestion within the last hour. Intubation is rarely required. Management is primarily supportive. There is an antidote, flumazenil, a benzodiazepine receptor antagonist. The problem with this is that most patients really don't need a reversal of the effect. 0.2 milligrams IV over 30 seconds followed 0.3 milligrams every minute to a total of 3 milligrams. If no response, then it's unlikely this is a benzodiazepine that's causing the respiratory depression. If there's a partial response, you can give additional flumazenil up to a total of 5 or maybe 10 milligrams total. But it really is not a part of most treatment strategy, because if you have to, you can intubate and ventilate these patients, and respiratory depression is generally the mode of death if you administer high enough doses of benzodiazepines. You can give flumazenil through the endotracheal tube. One of the precautions, if the patient's taken a tricyclic antidepressant, excuse me, or has a history of seizures, then you don't want to give the flumazenil. That's the big problem with reversing the effect of flumazenil, of benzodiazepines with flumazenil, is that if you reverse that effect too rapidly, you may provoke seizures. So forced diuresis, hemodialysis are ineffective. Generally, again, benzodiazepines are rarely fatal. Most of the management is really supportive. The antidote rarely gets used. I guess with the exception of perhaps trying to determine if, in fact, this is a benzodiazepine overdose that's causing the coma or the unconsciousness. Amphetamines, this would include any variety of amphetamine. Most commonly, what we're going to see are methamphetamine, but methylphenidate, phentermine, other substances that are amphetamine-like that get abused. Most traditional amphetamines have been replaced by newer synthetic type agents, but management of these kinds of drugs is all fairly similar, and so hyperreactivity, irritability, delirium, hallucination, psychosis, mydriasis, hyperpyrexia, flushing, diaphoresis, hypertension, and arrhythmias are the common manifestations of amphetamine overdose. Less common, perhaps more severe, though, would be infarction, myocardial infarction, seizures, acute renal failure, and aortic dissection because of the increase in blood pressure. Management: lavage for a recent ingestion within an hour, activated charcoal. Emesis is contraindicated. Patients that are agitated, benzodiazepines will work quite well for that. Haloperidol for hallucinations or psychosis, but remember, haloperidol can cause torsades, so the patient need to be monitored, electrocardiographic monitoring. For hypertension, beta blockers, nitroprusside, phentolamine would be considered. Seizures, benzodiazepines and phenytoin. Hyperthermia, typically cooling blankets, maybe dantrolene. And dialysis is not clearly effective. So again, most of the management here, is it's indirect. Amphetamines tend to promote release of catecholamines, and it's a sympathetic nervous system reaction. So managing blood pressure, myocardial ischemia, seizure is really kind of, it's a supportive management strategy for these folks. So again, I think I wanted to emphasize, one, that clearly we haven't covered every potential compound that you're going to encounter in a critical care setting. But what I've tried to do with this presentation is to cover the substances that you're going to encounter on a most common basis. And again, the strategy, I think, is that for most healthcare providers working in an ED environment, you're going to need to have recognition of resources that are at your fingertips, if you will, because unless you just do this on a real constant basis, you work for a poison control center, a lot of this is going to be stuff you need to go back and refresh and have resources available that help guide you through your management strategies. So I think that's one of the key messages I'd like to leave with you is that our memories sometimes serve us well. Other times when we don't see things on a common chronic basis, it's best to double check your references before you proceed with management. So with that, I'm going to stop, and I thank you for watching.